This presentation focuses on a deadly yet preventable condition, pediatric abusive head trauma. My name is Jessica Campanile. I am a third-year medical student at the Perelman School of Medicine at the University of Pennsylvania, and I just completed my neurosurgery clerkship. To start, let's define abusive head trauma. Abusive head trauma, or AHT, is a preventable and severe form of physical abuse that results in an injury to the brain of a child. Previously termed, quote, shaken baby syndrome, it often occurs when a child's crying causes anger or frustration for the caregiver. Abusive head trauma had previously been termed shaken baby syndrome. However, now the American Academy of Pediatrics recommends the use of the term abusive head trauma. This is in order to account for mechanisms of abusive head trauma other than shaking a child, such as blunt impact or the combination of shaking and blunt impact. It also accounts for the primary and secondary injuries resulting from AHT, including sequelae like seizure disorders, developmental disabilities, and vision loss. Using the term abusive head trauma also limits semantic legal challenges. The term is both broader and more accurately descriptive of the presenting injury than the previous term of shaken baby syndrome. AHT is a leading cause of death among infants and young children. In the first year of life, AHT occurs in 20 to 30 per 100,000 children. More than 2,000 children are hospitalized annually as a result of AHT in the United States. These young infants are especially vulnerable. Children are at the greatest risk of abusive head trauma at ages 0 to 3, with a median age of 4 months. At least one of every 4 babies who experience abusive head trauma dies. Abusive head trauma accounts for about 1/3 of all child maltreatment deaths. So, what should providers look out for? Warning signs of abusive head trauma include caregivers who may give inconsistent stories, injuries to multiple organ systems, and injuries or histories inconsistent with a child's developmental stage. For example, bruising on the extremities in non-ambulatory infants. In up to 1/3 of abusive head trauma patients, findings that are inconsistent with the child's developmental stage are uncovered. Clinical signs of abusive head trauma include subdural hematomas, retinal hemorrhages, and encephalopathy. The coexistence of acute and chronic subdural hematomas drastically raises the suspicion for AHT. Other findings of AHT may include visible scalp bruising or skull fractures, and concurrent findings may include rib, spine, and scapula fractures. However, AHT can be tricky to diagnose. It can mimic non-abusive head trauma with symptoms like vomiting, irritability, and poor feeding, which are non-specific. This contributes to the incidence of misdiagnosis, which is estimated to be between 18 and 31%. Abusive head trauma can also present with retinal hemorrhages, especially those that are bilateral, severe, and include the posterior pole and periphery are characteristic of abusive head trauma. Often, when children presented with acute abusive head trauma, there was not a chance to undergo fundoscopic evaluation prior to an urgent neurosurgical intervention. This led to confusion and suspicion that retinal hemorrhages discovered postoperatively may be attributable to the procedure. However, this has since been disputed, and the presence of retinal hemorrhages, even after neurosurgery, is still suggestive of abusive head trauma. When evaluating a child with a possible case of abusive head trauma, it's important not to anchor and to consider other causes of similar injury patterns. For example, subdural hematomas can be the result of a vaginal delivery, fractures may be the result of osteogenesis imperfecta, coagulopathies can lead to hematomas or hemorrhages, and congenital venous malformations in the brain can lead to some of the imaging findings of intracranial hemorrhage. For a child with acute symptomatic neurological trauma, the imaging of choice is a head CT. These children will often be admitted for a later MRI. asymptomatic infants may be admitted for observation and an MRI. MRI has the added benefit of lacking radiation exposure to the infant and is also more sensitive for detecting parenchymal hemorrhage or contusion and for distinguishing between compartments. Pediatric head trauma guidelines are less well defined than those of adults. In children presenting with cerebral hemorrhage, ICP monitors may be placed as in adult patients. However, if a patient's fontanelles have not yet closed, it's also acceptable to complete serial head circumference measurements to assess for increases in intracranial pressure. For infants who have experienced abusive head trauma and have an intracranial hemorrhage, as well as an open fontanelle, a subdural drain may be placed, or a fontanelle tap, as pictured below, may be attempted. Other than gaining control of intracranial pressure, most of the care for children with abusive head trauma is supportive. About 2/3 of children who experience abusive head trauma will have seizures, many of which are subclinical. Seizures are difficult to detect in an infant, especially those which are subclinical. In this case, non-responsiveness to noxious stimuli, even while their eyes are open, is highly suggestive of cerebral dysfunction. Some centers will treat these patients with prophylactic AEDs and continuous EEG monitoring to look for a seizure. For some patients, seizures occur and persist long after the initial injury. Other sequelae of abusive head trauma can include vision loss, hydrocephalus, which may require shunt placement, and developmental disability. Abusive head trauma in infants is also associated with cerebrovascular accidents, or CVAs. In a study of 282 children who had experienced abusive head trauma, 28% were found to have one or more CVA. The study was not able to differentiate between age, sex, race, socioeconomic status, or insurance status in a child's risk for CVA. What we do know are that CVAs increase mortality in abusive head trauma. 25% of children in the stroke cohort died as a result of their AHT, while only 1% of the non-stroke cohort died. So what can neurosurgeons do to prevent abusive head trauma from happening? When consulted for pediatric intracranial hemorrhage or skull fracture, neurosurgeons must have a high level of suspicion for abusive head trauma. The Pediatric Brain Injury Research Network calculator can assist in this. It helps estimate the probability that an injury is due to abusive head trauma based on 4 key variables: respiratory compromise, torso, ear, or neck bruising, bilateral or interhemispheric subdural hemorrhage, or any skull fracture other than an isolated, unilateral, non-diastatic, linear parietal skull fracture. Adding any one of these variables increases a child's probability of being abused by differing amounts. Providers can then utilize this tool in their clinical decision-making, such as whether or not to consult a child abuse pediatrician. Neurosurgeons have the ability to contribute to abusive head trauma prevention efforts. They may do this through public health and advocacy work, or through patient, family, and medical trainee education. In fact, in-hospital parent education regarding violence against infants has been shown to significantly reduce the incidence of abusive head injuries. If a neurosurgeon's institution already has a program like this, they may be able to reach out and offer any knowledge that they can or neurosurgical perspective on the issue. If a neurosurgeon's institution does not yet have a program like this, they may consider partnering with a child abuse pediatrician or other professionals to create one. Why is this all important? Why does this matter? Missing cases of abusive head trauma can lead to repetitive trauma and later death when children are returned to their abusive caregivers. The best method of treatment for abusive head trauma is prevention. If you suspect child abuse and you need help reporting, you can call the number listed on this screen, 1-800-4-A-CHILD, or 1-800-422-4453 to talk to a trained hotline counselor. While this hotline is not a reporting agency in and of itself, these counselors are able to talk with professionals about the signs and symptoms of abuse, what they can expect when they report abuse, and they can also provide the contact information of the relevant local reporting agency. Thank you for your time and attention learning about this important issue. If you have questions or comments on this presentation, you can reach me at the email address listed below. I'd like to thank Dr. Stephen Brem for giving me the opportunity to present on this topic and for the care and expertise he offers through the neurosurgery rotation, as well as the entire neurosurgery department for having me as their guest for the last 2 weeks.